Well, good afternoon, everyone, and thank you for joining the Superior Health Quality Alliance Roundtable conversation. My name is Kim Heft, and I am joined by my colleagues, Kelsey Ostergren and Jill Hansen, as well as our guest speaker today, Dr. Cheryl Huckins. For those of you that have been joining these meetings since January, and I know you've been out there since January, been here a long time, welcome back. And those who are new to the call, we're glad that you're here. We host this event each week. It consists of a 30-minute educational session where we highlight important topics related to COVID, including vaccinations and boosters. And then we follow that up with our Q&A session. Now, we hope you'll be able to join us each week. And one thing, though, I do ask is that you think about things that you're struggling with or you're trying to figure out, because these could possibly be future topics for us. So if you think of anything, please send me a direct message in the Zoom chat, and then possibly we could have a future session with that topic. Now, there will be a survey at the end of the session, which we would ask you to take a few minutes to complete. And Kelsey is going to be putting the link for the PowerPoint presentation and chat in just a moment. Please use the chat box to share any comments, questions, or anything that pops into your mind during the presentation. And then we'll use that for discussion in our Q&A portion of the event. Our speaker today is a Dr. Cheryl Huckins. She is a certified medical director and vice president of the Michigan Medical Directors Association. She has over 27 years of long-term care experience and the last 8 years in the role of a medical director in a long-term care SNF facility. So thank you for being here, Dr. Huckins. The floor is yours.
Well, good afternoon, and thank you all for allowing me to speak with you today. As Kim said, I've been working full-time in the extended care facility sphere for 27 years, and it is my passion. That is why I'm energized today to work with you on one of our greatest challenges, which is retaining and recruiting our care force. Next slide. Our objectives are to be able to describe the 4 M's of the post-acute and long-term care force. Secondly, is to describe the components of what matters to our staff. Third, it's understanding the importance of health promotion, safety, and streamlining tasks for our care force. Fourth is to consider opportunities for career mobility for our staff. And finally, to understand the critical importance of staff well-being, to avoid burnout, and to have a healthy work environment. Now, you may have noticed that I referred to care force instead of workforce. As we address this problem, we need to think about the roles of our nurses and CNAs differently. Truly effective people in these roles are first and foremost caregivers. They're not assembly line workers doing the same action, patient after patient after patient. Those who are remarkable in their role are caring, and that's what we want from our team members. Care force has a more compassionate sound to it, and it denotes empathy and concern. Let's call it what we want the role to be. Everyone has been aware of our crisis in our workforce since even before the pandemic. McKnight reported that in 2017 and 2018, we had an overall 94% turnover in all of the care force. Turnover rates for RN were at 140% and nursing assistants at 129%. What COVID did was shine a very bright light on our challenges in employment. Between 2020 and March of 2020 and October of 2021, we lost 221,000 employees which is a 14% drop in our staffing. Staffing shortages have become critical. Next slide. Many organizations are working on how to address the retention and recruitment issues. AMDA, which is the American Medical Directors Association, and also known as the Society for Post-Acute and Long-Term Care, developed a roundtable series called More of a Good Thing, a framework to grow and strengthen the Peltec care force. They are bringing leading experts in their fields from around the country to sit and brainstorm ideas of how we close our staffing gap. I'm going to invite you at the end of my talk to join this conversation. Next slide, please. Many of you have heard of the Age-Friendly Healthcare System Initiative. It was started in 2017 by the Institute for Healthcare Initiatives, supported by the John A. Hartford Foundation, to address what was lacking in most healthcare systems: an age-friendly type of care. It's founded on the 4 pillars of care, known as the 4 M's. And that is what matters to a patient, what medications they're taking, what their mentation is like, and mobility. If a system has addressed all 4 of these issues, then they are acknowledged and can actually be certified as an age-friendly system. In healthcare, we think what matters means that we align the care to a patient's goals and care preferences, which can include advanced care planning, goals of care, wanting to be home with their dog, whatever it is. Medication is looking at medicines continually of what an older person is taking, that we're not actually creating problems with side effects or drug interactions, and hopefully reducing medications to avoid those interactions. With mentation, we specifically want to address, is there depression? Is there dementia? Has a delirium developed? And the 4th pillar, mobility, is to ensure that every older person is kept active every day so they maintain their function as long as possible. Next slide, please. So the 4 M's of the roundtable are very similar. What matters to the staff? Medications, they've broadened that meaning to be speaking to health promotion and safety, mobility, and we're talking about career path mobility, and then mind, which is well-being of your care force, avoiding burnout, and having a healthy work environment. Next slide. In terms of what matters, what we need to do is look at the culture of a facility. Do we treat each other with respect and kindness? Are the diversity, equity, and inclusivity values demonstrated by leadership and then shared by the care force? Is there a sense of corporate social responsibility? Does the organization look out to the community to do good? Perhaps a food drive annually or a Alzheimer's walk initiative. But do we also collaborate internally, seeking input from everyone? Do we ask our CNAs for patient-specific ideas for care planning behaviors that affect others? And if not, why not? CNAs probably know best how to address the behaviors of a particular resident. Are the staff referred to by their name, particularly by their physician? Or are we recalling the nurse down the West Wing without bringing her name in? Are apologies given when there is an adverse impact on others? Has anybody said, I know it's going to be difficult for you to be back in 8 hours to pick up the next shift, and I'm sorry that that had to happen? Are staff thanked sincerely? And do you check in on your staff, asking, are they okay? Do they need anything? Is feedback welcomed? Do you ask, are we hitting our mark? Are we doing what we said we're doing to your staff? Next slide, please. Under the medication, health promotion, safety, and wellness pillar, it's having enough personal protective equipment for them not to be fearful that they have an increased risk of becoming infected or injured. Do you have proper equipment in good working order and available? Are the Hoyer lifts always missing and people are running up and down the halls trying to find them? Are the weight scales put back in place every time? Running around trying to find the equipment you need is exhausting, it's frustrating, and sometimes people just skip that step because it wasn't easily available. Does your organization have good health benefits and a robust paternal family leave? Do you have opportunities for social meetings? Is there a book club that some of your staff participate in? One organization had yoga classes at the start of a shift or right before a shift, and the charge nurse would kind of watch over the residents for the 15 minutes that the yoga class took place, but it was very well received and appreciated. Do you have walking teams that go out and walk the perimeter during their break? How about healthy snacks in your vending machines? Or are they all potato chips and candy? Encourage everyone to take a non-working lunch. Next slide, please. Another form of wellness protection is assuring that our tasks are not just loaded on one after another on the plate of our CNAs and nurses. We tend to put more on than we take off. And we need to continually review what are essential tasks we're asking folks to do, and review, do you need daily weights on all those patients? Do you need the QID blood glucose monitoring? Do you need Q shift vital signs? Where can those things be safely reduced? How about med pass times? Can you consolidate to have fewer med pass times? Have you done a deprescribe performance improvement at your facility to reduce the number of meds that are being given? AMDA, that Association for Medical Directors, currently has a process improvement program to reduce meds by 25%, and it is successful. We've been doing it in our facility with really good results. What is the impact on your staff of all their time commitment for their tasks? Do you know what it is? If you don't, ask. They can tell you where their bottleneck in their workflow is. Next slide. Mobility has to do with career opportunities. Not all nursing assistants want to be nurses, although some may choose that path. But consider having options within the CNA role. What about having a lead nursing assistant who might mentor the new hires until they've had that aha moment where they bond with a resident? That is the point where a new hire realizes the inherent importance of their role, where they see themselves as a caregiver and not just a task performer. How many facilities hire CNAs and then put them out on the floor with no mentor, only to have them no-show by the end of the week? Our staff need to be introduced to our culture, shown why what they do is so important, and that their observations and their reporting of changes are valued. Put CNAs in your quality work groups. What if CNAs were in charge of reducing the falls in your facility? What might they come up with? One facility had CNAs on one hall kind of have a friendly competition with CNAs on another hall to see who could reduce their fall numbers the most. And finally, do you have any continuing education funds available to help people expand their experience and their knowledge base? Next. The well-being area includes making sure people have time to decompress. Many of you have paid time off. Do you know who's using it and who isn't and is losing it? Encourage taking time off. And even in these days where we are always short-staffed and people are always putting in extra hours, extra weekends, offer what you can. Can you give a half day off for someone who's been working 10 days straight just to give them a little time outside the facility? Check in with your staff after stressful or emotionally charged events. Deaths are very hard on staff, and how do we show compassion to them? One facility I've worked for has had what is called compassionate passing. When a death occurs and the funeral director is ready to bring the body down the hallway, it's covered in a special quilt, and an announcement is made that there will be a compassionate passing in a few minutes. That means at that time, the staff will line up in that hallway, shoulder to shoulder, nursing, physicians, therapists, housekeeping, dietitians, maintenance, and stand quietly as the patient is rolled by. That's a very powerful moment, and it brings together everyone that works on your team for a moment of silence and respect and honor to our resident. Next slide. I'd like to invite you all to look up the possibility of participating in the Roundtable. I've given the link in the slide here, and I want to thank the folks at AMDA who have been working together on this initiative, including Erin Vignier, who's an RN, Joanne Reifsnyder, who's a PhD RN, and Emily Nickel, another RN and nurse practitioner. Our organization is not just for physicians, not just for medical directors, but it really is for everybody who works in the post-acute and long-term care setting. I think the more we work together, learn together, brainstorm together, the better we'll all be. Thank you. And are there any questions?
Thank you, Dr. Huckins. Yeah, at this time, please feel free to unmute yourself, ask Dr. Huckins any questions that you may have. I know that she's been at one nursing home for the last 8 or 9 years as medical directors, as the medical director, and has seen a lot of change in regards to the 4 M's. I could see how some of what she talked about is definitely would go towards the 4 M's. Actually, while people are thinking about questions, again, in chat or unmute yourself, Dr. Huckins, you mentioned that on AMDA, there's something online. Did you say there's some form of a template or a process for reducing meds? Is it an actual, what is this thing?
Yeah, it's a process improvement program called the Drive to Deprescribe. And we at the facility I've been at have used it as our guiding template for reducing medications in a very careful way, because what the AMDA will do is have a meeting once a month, a half-hour, 45-minute talk on by a pharmacist on a medication category. It might be anticoagulants, it might be antipsychotics, and then request that your team meets once again in that month to see how we can apply that principle, sharing the side effects that might be helpful for a family member to understand that these drugs have consequences that can sometimes actually make things worse, can increase falls, can increase fatigue and loss of appetite. As we all have seen, you put somebody on hospice and suddenly they might brighten up when their medications are significantly reduced and they may start to eat better. And we have come close to that 25% reduction in medications by a careful review. And it's a interdisciplinary process by which we do that. We talk about what we're going to focus on, and then nursing staff will bring forward to the physician, or in our case, it was a nurse practitioner, suggestions for reduction. If it was a PPI, the nurse practitioner would review the meds, and then for the next care conference, the nursing staff, the charge nurses, would talk with the family and the resident about why the provider is recommending reducing this and trying, and they would have been educated in the reasoning. And with that, we do have a good family participation and agreement. So I think what we've learned is the interdisciplinary nature of bringing everybody to the table and their particular skills, their relationships with patients and families, is probably the best way to bring about changes when we all are working together on it.
Thank you. And again, we could probably find this at, I was like, I didn't have time to go and search.
Oh, sure.
But on AMDA, Drive to Deprescribe, right? Just
yes. And I can send you the link if you want to put it out afterwards.
Yeah, absolutely. Okay. Mm-hmm. Thank you for that.
You're welcome. What is everybody thinking and doing to help improve their staffing? I know wages was a concern, always is a concern. But actually, when you talk to large numbers of CNAs, for instance, it's not just the money. It really is having job satisfaction and feeling that you're being respected. And if you come to work and don't hear that, it's easy to just move over and go to work for Costco at $25 an hour. But if you have a staff member who is engaged, who really sees her work as a profession of caring, that's a valuable person you're going to have for years and years and years working for you. So I'd be interested to hear how other people are engaging with their staff to try to retain and then hopefully recruit.
You know, somebody's got to say something. There's got to be someone that's got something on their mind that they're just willing to share. Or what? Oh, and if you can't think of anything, I don't mean to say like there's just like there is no magic bullet, but what has brought what has at least helped a little bit, or actually, yeah, what has happened, what has not worked at all can even be something to share.
Mm-hmm. Have the signing bonuses been helpful? I've been told that people just leave after 90 days. They get their signing bonus and then move on to the next.
Hello, I have something to offer.
Hi, Nancy. Sure.
Hi, I've shared this with our association as well about we're a smaller facility, we're only 30 beds, but one of the things we were able to do is to change our staffing. So instead of, we change it into more of a primary care nursing role, so that where we could hire nurses but not CNAs, we had nurses divide a wing where, let's say for 15 patients, it used to be one nurse and two CNAs. Now it's two nurses and one CNA. So the nurses split the med pass, and they also assume care on each nurse has 4 residents. So it puts us nurse heavy, but we're able to maintain our staffing numbers. And I have to say that satisfaction for the nurses that had been here for a long time wasn't great, but the new nurses that we brought on and are aware of this staffing pattern from the beginning haven't had any complaints about it. We're also then able to take our CNAs that are in school to become LPNs and then RNs, and then put them in and maintain them on our staff rather than losing them when we don't have an RN position. So it's really, I think, been really beneficial. You know, we've had sign-on bonuses and referral bonuses. We're really getting rid of the sign-on bonuses because we're part of a hospital, and they looked at how effective those sign-on bonuses were and how much recruitment was really done because of them. And 8 out of 10 people said the reason they joined our facility was not because of the sign-on bonus. And so we were also really worried if the sign-on bonus really brings in the kind of people that we want as part of our culture, if that is, you know, their primary reason for coming. So we're ended the sign-on bonuses in May. We've also had another company come in and look at market adjustments for all our positions to make sure that we are up to snuff, and we have had several pay increases in different areas. So those are some of the things that we've done that have been successful. A lot of bumps in the road, though, with changing our staffing like that, things that we didn't originally consider that we've had to make adjustments for. But all in all, I think it's worked out.
Thank you, Nancy. I was thinking about when you're talking about having nurses doing primary care. I think you had said it was more well received by the new nurses you brought on, but maybe not so much by the nurses that were already working there. How did you combat that transition for those that were there? Did you lose nurses due to that primary care?
No, we didn't lose anyone. We didn't lose anyone. And so what we've been able to do is, so we have 2 wings, and with, say, if one wing we have 2 nurses doing, you know, the primary care, and the other side, you know, if that one nurse who might be more resistant or maybe even less physically capable, because I know I would not be great at doing cares at all, you know, then they can stay on the other side. So we haven't, but you know, we've heard grumblings, but we have not lost anyone because of it. You know, the team works pretty good, and we just, you know, do what we can. But I think everyone knows that it's been a difficult journey, and I think they're willing to try, just as long as we have, you know, enough staff.
Thank you for sharing.
Sure.
Thank you very much.
Hey, Nancy, this is Jill Hansen with Superior Health. Question for you. When you came up with this idea for sort of changing your staffing model, how did you come up with that idea? And sort of where did that idea come from?
Oh, well, can you hear me? I don't know if I'm, okay. My background is, I worked in an acute care hospital, in a larger hospital in Milwaukee. And I remember that when things would happen and all of us in our staffing would fall apart, we started doing that sort of thing. The nurses would just go into the role where they would, now granted that kind of, being a caregiver in an acute hospital was a lot different than it is when you're trying to take care of everyone's ADLs, but it was the same basic principle. And I looked at that, and I looked at also, again, we had a lot of CNAs that were going on to school, and that it provided that opportunity to keep them, the not have to have the cost of reorienting new nurses or new CNAs all the time, but instead having them just gradually go into that role. That was the other thing that I looked at. And, I'd much rather keep our nurses or our staff than having to worry about bringing travelers. And the nurses staff also agreed, they would prefer just having our own caregivers. So it was harder to get that passed with senior leaders and finance, but I think when they looked at all the other costs involved, it was not very difficult to convince. My finances don't look as good as they used to, but it's okay.
I was going to say, yeah. Sometimes it's, they're looking for that return on investment. So,
right. Absolutely.
Yeah. And so the reason I was sort of prompting you with that question is because when you think about within your organization, your frontline staff know exactly, as I think Dr. Huckins sort of alluded to it in her presentation, that they know exactly where the hiccups are and those bottlenecks within your organization. So, finding ways to solicit feedback from them. I mean, when we walked through sort of each one of these components, I really like the idea of sort of that age-friendly health system and sort of taking that lens from what matters to staff in terms of that health promotion, safety, that career path, and then really that well-being. I think even if you left this call today and said, you know what, can we pick one of these to focus on and start to look at how we can start to incorporate some of this if we don't already have it within our organization. So, again, and each one of these, again, said, how are you soliciting feedback? And so that's just another thing to think about, is really engaging your frontline staff. So I appreciate that conversation, Nancy, and you sharing sort of a staffing strategy that you've used, and think about it. So you came from a different organization within that acute care setting. You brought that to the nursing home setting, and it's really about thinking outside the box, because as we know, the staffing issue is probably likely going to continue to be an issue outside of any pandemic. I think that's something that regularly happens with organizations. And so the more that you can sort of flip the lens and start to be creative thinking, and really engage your staff, and not engage staff, not just the same 6 staff people that you tap on the shoulder to engage. And so I liked the idea of, with the new staff coming in, they really liked this sort of new format, and you still left that opportunity to say, if you're not necessarily able or comfortable at this time to sort of do that 2-nurse track, we have another unit or, wing that you're able to focus on. So it doesn't sort of force everybody into something, and it allows them to sort of move over as they see fit.
Do we have any other questions? What are other people doing or actually, as Dr. Huckins was talking through this, I was thinking about the place that I at the nursing home I used to work at, and about how, oh yeah, that makes sense. We did that, or oh, that would be a good idea, or what have you. What are other things you're already doing that would fit into the 4 M's? Any other things that you would be willing to share with your peers?
Hmm. Certainly, I've seen, that corporate social responsibility outside in the community where the nursing home sponsors something. Sometimes we've sponsored an educational session, not just for family members, but for the community at large on dementia. What is dementia? Or showing the mortality movie and talking about advanced directives, having the Alzheimer's walks or the food pantry or the other collections to do something in the community, which does do a lot to bring staff together, not just in the work mode idea, but together as people with a common cause. And I think that has always shown the facilities that do that a greater sense of caring, that the staff see this as more than just a job, that it's a part of who they are, and that the organization does look outside itself to try to improve the community. That causes a facility to stand out. And I think it does build goodwill by engaging the staff.
I'm going to ask for a show of hands. How many of you have had a pizza party at your organization? And the reason I ask that is because I know we're sort of pizza partied out. So,
who hasn't, right?
I mean, nothing wrong with a good pizza, but
at our organization, the activities people for Valentine's Day had to buy a balloon for a Valentine's gift to your favorite caregiver or friend, or to thank somebody. And it turned into an explosion of balloons at our place. Hundreds and hundreds of balloons. Family members bought them for staff members. Staff bought it for residents. It really was quite over what anybody expected in terms of its impact of showing of care. And that was just simply, $1 a balloon, and the activities people spent all day delivering balloons to multiple people.
Did they get to write a little like note in there? Is that what it was? Like a little
Yeah.
thing? How fun. Oh,
Thank you.
sounds like a lot of fun.
Yeah.
So kind of like Jill's question about, who had a pizza party, kind of, that's on a funny note, but I have a question to challenge all of you is what do you think the culture is in your building? If I were to, go in and just spend half a day or a day, how would I walk out feeling? Would I be feeling like, wow, this is the place I want to be? Everyone is like welcoming, they work together, you can tell everybody's respected, they can say what they want without feeling penalized, or is that the kind of culture you have in your building? Or would I walk out feeling, I don't know, I don't know if I want to work here? Do any of you have a what do you do? What do you do in your building to promote positive culture?
How many of you would say that you have a top-down hierarchical style of leadership? That the rules, the policies, and all come down from leadership and are dispersed? And how many of you have a collaborative type of leadership or a servant leadership where you see your role as removing obstacles for your employees? And I think I'd ask you to look very, very thoughtfully at that. It's easy. We all want to be servant leaders, but are we really? I think that's a very serious question to think about.
Does anyone use their frontline staff in their decision making, like for a new process, a revision of a policy that isn't working? Do you bring them in? And anybody have a good example? Cheryl, Dr. Huggins, do you have any good examples of that, like of a good revision? I know it's so hard to think right off the top of your head. That's probably how everybody
Yeah.
else is right now.
Yeah.
Like, I can't think of anything. Yeah.
Well, I come back to thinking on the behaviors and struggling, because frequently we've struggled with reducing our Casper scores for behaviors affecting others. And do we bring in the people who really know and can come up with the ideas specifically? And when we sit in meetings sometimes with not everyone who is familiar with the specific resident we're talking about. And I really would like to see more of having that CNA or a CNA who's familiar with that patient, or at least the nurse, be able to comment on what does work for that resident. What does putting on music when you're trying to give a shower, does singing with them and have them sing along. Music is quite a comforting thing for many, many people. And I don't think we use it enough in the nursing setting, nursing home setting. And those are things that I feel being able to have your CNA participate even for 5 minutes to give her thoughts, his thoughts on a particular resident and what they've seen work, and then brainstorm about, okay, how do we spread that for everyone to know, and what things do we need to avoid? So although I haven't come up with a specific policy, I know, was brought forward, that would be something that I would love to be working with a larger portion of different staff roles to help in solving some of those persisting issues.
Yeah, it's always felt it was easier said than done. We all know that we need the frontline input, right? But then when we're having that meeting, we're having that discussion or what have you, they can't come to the floor right now. They're right in the middle of a shower.
Right.
It's
Right.
tough. It's tough. Well, does anyone have any other thoughts or comments? Oops, sorry.
Hey, Kim, I would just add, for those of you, so now we gave you some homework, all of you, with sort of, thinking about which of those four, what matters, the medication, the mobility, or the mind, what you want to take back to your organization. One of the things that I'd encourage you to keep in mind is, and every single one is Dr. Huckins mentioned, sort of that elicit the feedback. Just remember that if you're going to ask for feedback, be sure to be thinking about how you're going to circle back with your staff to say, you know, what it looks like. So one is, you know, do you have a box that says idea generator somewhere on the unit, and someone regularly pulls all the information like suggestions for improvements or however your focus you want it to be. But then really, how do you continue to circle back with your staff to say, where are we at in this process? And you also want to think about if you have things that you've done, that you've implemented changes within your organization as a result of a suggestion from a staff person. Those are great things to bring back and highlight so that everybody knows. Because sometimes what happens is we ask for feedback and we do a staff satisfaction survey, but I never hear anything. What happened with the results? So as a staff person, I might go, why would I give you my feedback and nothing happened? So just when you're thinking about, you know, if you're going to solicit feedback, what does that process look like for you? So if that's one area that you're like, you know, I'm not sure what our process looks like, that might be one to take back as sort of an idea to talk about with your leadership team and think about, are we asking the right people? As Dr. Huckins mentioned, if it's top down within your organization, it's really hard for people to wrap their head around and be supportive of a process change when they have no idea why that process change is happening. And maybe it was from an idea that someone had, but that sort of loop wasn't closed. And so staff don't necessarily know that that's why that came about. And so it sort of builds that camaraderie. It starts to shift the culture within your organization because you're encouraging staff to bring suggestions forward, good or bad. Because again, that's all part of the quality improvement piece, is where you're sort of teasing out ideas to have. So again, recognizing the ideas within staff and knowing that every idea is you're going to be able to implement, but at least they're understanding that their voice is being heard and that somebody's actually circling back with them to let them know sort of where
That's an excellent point. Communication is to be both ways.
Absolutely. I'm pausing for, I know it's silence. It's hard for me not to talk because I know people are like waiting for somebody to just possibly have one more comment or a suggestion. You know what we didn't hit on? Is anyone doing anything for career ladder in particular? Maybe a care conference liaison. Dr. Huckins mentioned, you know, mentoring new staff. Maybe a lead CNA that is the spokesperson for all the CNAs type of a role. Anyone, what are you doing? I'd like to hear that because I know career ladder is important to a lot of CNAs because they feel like sometimes they can't go on anywhere else, but they don't want to be a nurse. Anyone doing anything interesting, anything different? Or maybe you aren't yet, but you're thinking about it. Well, okie doke. So on that note, I believe that we'll have to, let's see here. Oh yeah, okay, we got 10 minutes, but if there isn't anything further, we can say goodbye until next week. I believe next week we're going to be talking about medical directors and what a medical director should be doing for you in your organization, and maybe even things you didn't even think about. Different twists, things have changed with COVID. So what could your medical director be doing for you? And that's going to be with Dr. Cheryl Huckins again. So I hope to see all of you here next week. Everyone have a great week, and thank you for attending. And don't forget to fill out the survey. Thanks. Bye-bye.
Thank you.